Good day. My topic for today are the diseases of the salivary glands, oral cavity, and oropharynx. The objectives of this lecture is to learn the different diseases of the salivary gland, oral cavity, and oropharynx, and be able to familiarize and diagnose these diseases. There are three major salivary glands that I will discuss today. Parotid gland is found at the lateral aspect of the face. Anterior border is the masseter muscle. Superior border is the zygomatic arc. Posterior border is the tragal cartilage and sternocleidomastoid. The deep border is the pre-styloid compartment of the parapharyngeal space. Inferior tail of the parotid is between the ramus of the mandible and the sternocleidomastoid muscle overlying the digastric muscle. The superficial and deep lobes of the parotid are divided by the facial nerve. 80% of the parotid parenchyma is the superficial lobe. The parotid is overlying the posterior aspect of the mandible and covered by your parotido-masseteric fascia. The Stenson's duct traverses over the masseter muscle, and the duct punctum exits the oral mucosa adjacent to the second molar. The superficial and deep lobes of the parotid gland are divided by your facial nerve. The extratemporal segment of the facial nerve exits the cell base through the stylomastoid foramen posterolateral to the styloid process and anteromedial to the mastoid process. The facial nerve branches as it enters the parotid, forming the pes anserinus. The upper division includes your temporofacial branches, and the lower division includes the cervicofacial divisions. The submandibular gland is found in the submandibular triangle, and the superior margin of the submandibular triangle is the mandible, and the inferior margin are the anterior and posterior bellies of the digastric muscle. The Warthin's ducts open in the floor of the mouth and cross into the lingual nerve. The facial artery courses deep to the posterior belly of the digastric muscle. The facial nerve via the chorda tympani nerve provides secretomotor innervations to the submandibular and sublingual glands. The hypoglossal nerve provides motor function to the tongue and is medial to the digastric muscles and the submandibular gland. Lymph nodes of the submandibular gland are periglandular. The sublingual glands are paired. They are located opposite the lingual frenulum and superior to the mylohyoid muscle. The sublingual glands are drained by 8 to 20 excretory ducts called the ducts of Rivenus. Other minor salivary glands located throughout the upper airway but are concentrated in the oral cavity, especially the palate, with a number of about 600 to 1,000. Saliva is a complex mixture of electrolytes and macromolecules secreted from 3 pairs of the major salivary glands and numerous minor salivary glands. The secretion of saliva is tightly modulated by a multitude of factors that include the autonomic nervous system, humoral factors, and disease states. The basic unit of salivary gland consists of your acinus, a secretory duct, and a collecting duct. Saliva is formed via an active processes that occurs throughout the secretory unit. These processes are under the control of complex neuronal and hormonal signals. The flow of saliva is regulated by the autonomic nervous system. The parasympathetic cholinergic stimulation is dominant and uses mostly the neurotransmitter acetylcholine to activate phospholipase C. Its functions include fluid formation and transport activity in the acinar and ductal cells. Sympathetic beta-adrenergic neurotransmitter is predominantly norepinephrine. Its functions include exostosis and protein metabolism in the acinar cells. Sodium chloride bicarbonate are secreted in the acinar lumen after the parasympathetic neurotransmitter. Acetylcholine attaches to the parasympathetic M3 muscarinic receptor. Saliva is 99.5% water and the remainder are proteins and electrolytes. The range of normal unstimulated salivary flow is 0.1 ml per minute and above. In the stimulated state, it is 0.2 ml per minute and above. On average, the unstimulated flow rate is 0.3 ml per minute, and the stimulated flow rate is 7 ml per minute at maximum. Stimulated saliva is thought to contribute as much as 80 to 90% of the average daily salivary production. This leads to an average daily saliva secretion of around 1,000 to 1,500 ml, or an average of 1 ml per minute. Salivary flow in the unstimulated state is produced primarily by the submandibular glands, and the parotid and the sublingual glands produce only 25 and 3 to 4% of the flow respectively. Once stimulated, the relative contributions of the parotid and submandibular glands are reversed, and the parotid gland supplies 2/3 of the salivary flow. This is a table of the contribution to the relative viscosities of the saliva by the salivary glands. Just check this table in your books. The functions of the saliva include lubrication and protection, buffering and clearance, maintenance of tooth integrity, antibacterial activity, taste, and digestion. The major salivary glands are regarded as the principal source of your salivary antimicrobial substances such as immunoglobulin A, lactoferrin, lysosine, and peroxidase. Immunoglobulin A is the predominant immunoglobulin in saliva and is present at a concentration of approximately 20 mg per 100 ml. It plays an important role in the local immune system of the salivary gland. Salivary immunoglobulin A is increased by both sympathetic and parasympathetic stimulation. Immunoglobulin G and immunoglobulin M are also present in saliva, although at much lower concentrations. Now I will discuss the different diseases of the salivary gland. Acute suppurative cellulitis is a bacterial inflammation of the salivary glands. It presents as a rapid, diffuse swelling and pain over the affected gland, in addition to systemic manifestations such as fever, chills, and malaise. It is caused by a retrograde bacterial contamination of the salivary ducts from the oral cavity. Stasis of salivary flow secondary to dehydration or significant hemorrhage permits retrograde migration of bacteria and produces suppurative infection of the gland parenchyma. The parotid gland is the most susceptible to such infections. Predisposing factors might lead to acute cellulitis, so this includes diseases such as your diabetes mellitus, your hypothyroidism, renal failure, Sjogren syndrome. The most common pathogens associated with acute bacterial parotitis are your Staphylococcus aureus and anaerobic bacteria such as your Fusobacterium and Peptostreptococcus, which is a gram-negative bacilli. On physical examination, the patient might demonstrate signs of systemic dehydration with dry mucous membranes. Local findings include tenderness to palpation with warmth and induration of the overlying skin. Bimanual palpation of the gland results in suppurative discharge from the red and distended duct orifice in approximately 3/4 of cases. Imaging of the affected gland with CT or ultrasound for abscess formation is indicated in patients who do not respond to medical therapy within 48 to 72 hours. Ciliography performed in the acute phases of cellulitis provides little useful information and is contraindicated because it can exacerbate the existing inflammation. Diagnosis is by bacterial culture from the duct for active drainage. Treatment is an antimicrobial therapy that is initiated empirically toward gram-positive and anaerobic bacteria. Culture results should be used to further direct antimicrobial treatment. Surgical drainage of the loculated abscess is necessary. Complications of acute suppurative parotitis are osteomyelitis, thrombophlebitis of your jugular vein, septicemia, respiratory obstruction, and death are potential sequelae of suppurative parotitis. Chronic silidinitis is a localized condition of the salivary gland characterized by relapsing and remitting episodes of pain and inflammation. The submandibular gland is the most frequently affected site. The initial inciting factor is believed to be salivary duct obstruction, which results in salivary stasis and eventually in ascending bacterial infection. The most common cause of ductal obstruction is urceolithiasis. Additional causes include the stricture of the salivary duct, extrinsic compression by a tumor, stenosis secondary to scar in adjacent tissue, congenital dilation, and foreign body. Chronic inflammation can also cause progressive acinar destruction with fibrous replacement, thereby resulting in glandular atrophy and sialactasis. Clinically, patients experience recurring episodes of sudden onset of swelling and tenderness of the affected gland. A low-grade fever can occur in association with these episodes, and patients frequently report an initial episode of acute suppurative bacterial silidinitis. Asymptomatic intervals might range from a few weeks to months. On physical examination, this reveals enlargement of the gland, and frequently mucopus may be seen draining from the ductal orifice. Mucopus is more viscous than saliva and results in obstruction of your ductal lumen and salivary stasis. Staphylococcus aureus is the most common causative microorganism involved in adults, and the imaging modalities include ultrasound, CT scan, conventional MRI, and MRI cyalography. Initial treatment is conservative and involves oral antibiotics, massage, heat cyalogogues, and corticosteroids. Antibiotics are only effective if acute silidinitis is present. Corticosteroids, taper, can be used in short term to decrease inflammation, and hydration via cyalogogues and warm compresses serve to flush out the precipitated serum proteins within the salivary ducts. If this treatment fails, sial endoscopy can be used to wash out the intraductal system and dilate the ducts. Sial endoscopy serves as a diagnostic and interventional tool, generally if the patient suffers from more than one acute attack per year. Interventional sial endoscopy may be considered. Possible complications of chronic silidinitis include the development of a benign lymphoepithelial lesion near Kuttner tumor and the ductal carcinoma. Sialolithiasis may result in scarred stenotic ducts, sialactasia leading to diminished secretory function of the gland. Treatment includes your antibiotics, hydration, cyalogogues, wherein it would result in a 50% improvement. Removal of sialolith can return the gland function and obviate gland removal. Now let's discuss the benign neoplasms of the salivary gland. Benign neoplasms of the salivary gland represents less than 4% of all the head and neck neoplasms. Most salivary gland neoplasms occur within the parotid gland, of which 80% are benign in adults, and 50% of the submandibular gland and 20% of the minor salivary gland tumors are benign. The palate is the most commonly affected minor salivary gland. This is the latest WHO classification of benign salivary gland tumors, and most salivary gland diseases are benign. Most salivary gland tumors that arise in the parotid glands are benign. Most minor salivary gland tumors are malignant. Your pleomorphic adenoma or benign mixed tumor is the most common benign salivary gland neoplasm. The term pleomorphic was chosen to describe these tumors because they possess morphologic diversity with both epithelial and mesenchymal components in various proportions. They originate from an uncommitted, reserved cell of the intercalated duct that has the potential to differentiate into epithelial and myoepithelial cells. They occur most commonly in the major salivary gland. but may also arise from the minor salivary gland of the upper respiratory and alimentary tracts. The parotid gland is where most pleomorphic adenomas originate, which is superficial to the facial nerve. The pleomorphic adenoma of the minor salivary glands are commonly occurs in the palate, and the second most common site is the upper. Pathologically, your pleomorphic adenoma are solitary firm brown tumors. The cut surface is characteristically solid and may be hard, rubbery, or soft in consistency with a wartish gray to pale yellow color. Pleomorphic adenoma of the major salivary glands is a capsule, although it varies in thickness and completeness, whereas pleomorphic adenoma of the minor salivary glands is usually unencapsulated. On histologic examination, pleomorphic adenoma consists of an epithelial component that may take the form of ducts, nests, cords, or solid sheets of cells and myoepithelial cells that appear plasmacytoid or spindled in a fibrocollagenous mixochondroid or chondroid background. Almost all pleomorphic adenomas have focally thin capsules, and one-fourth of the pleomorphic adenomas demonstrate satellite nodules or pseudopodia. MRI is also superior to CT in demonstrating the internal structure of the salivary gland tumors in multiplanar fashion and in delineating the interface between tumor and normal salivary gland. Extension of the tumor beyond the fascial confines of the gland can be adequately seen on both CT and MRI and should raise the suspicion of malignancy. Ultrasonography has the advantage of being inexpensive, non-invasive, and simple to perform. It can be used to differentiate solid and cystic masses in the salivary glands. Ultrasound-guided biopsy may enhance the accuracy in the non-palpable tumors and in masses with heterogeneous architecture. So surgical excision with the facial nerve or marginal mandibular nerve preservation is the treatment for pleomorphic adenoma of the parotid and the submandibular gland. The risk of malignant transformation in pleomorphic adenoma is 1.5% within the first 5 years of diagnosis, but increases to 10% if observed for more than 15 years. Warthin's tumor is the second most common benign salivary gland neoplasm after pleomorphic adenoma. It is known as your papillary cystadenoma lymphomatosum or adenolymphoma. Your male preponderance and is more prevalent in Caucasians compared to other racial groups. This accounts for approximately 10% of all the parotid tumors and is found almost exclusively in the parotid gland or the periparotid lymph nodes. Bilateral Warthin's tumors occur in 10% of cases and may be simultaneous. It is also associated with cigarette smoking and may be due to irritation of the ductal epithelium by tobacco smoke, which initiates tumorigenesis. Patients with Warthin's tumor present with an asymptomatic slow-growing mass, often in the tail of the parotid gland. It is occasionally can be inflamed and painful. The treatment for Warthin's tumor is surgical excision, usually a parotidectomy, with facial nerve preservation. So on gross pathologic examination, your Warthin's tumor are usually ovoid masses that are encapsulated with smooth or lobulated surfaces. The papillary cysts are commonly found on sectioning and contain mucoid, brown fluid, and solid gray tissue encapsulates the white nodules of the lymphoid tissue. Microscopically, the combination of papilla of the eosinophilic epithelia that projects into the cystic spaces and lymphoid matrix is a distinct and pathognomonic histologic feature. The typical cystic lining is arranged in two cell layers of even rows. The apical or luminar tall, columnar, and basal cuboidal cells contain small dark nuclei and abundant granular pink cytoplasm. So the granular eosinophilia of oncocytes is due to abundant mitochondria present in the cytoplasm. So imaging that can be done are your MRI, CT scan, and an ultrasound. And the treatment for Warthin's tumor is surgical excision, usually with facial nerve preservations. Now let's discuss the malignant neoplasms of the salivary. Malignant neoplasms of the salivary gland are rare and represents approximately 3% of the head and neck malignancies. Less than 5% of all salivary gland tumors occurs in the pediatric age group. Although the salivary gland tumors in children were believed to be much more likely to be malignant than those in adults, 73% in the parotid, and of those only 15% were malignant. Minor salivary gland tumors constituted only 14% of the total number of cases, but 46% were malignant. Submandibular gland tumors constituted 11% of the cases, and 37% were malignant. Sublingual gland neoplasms constitute only 0.3% and 86% were malignant. This is a table for the incidence of malignant neoplasms of your salivary gland. And the most common primary malignancy in the salivary gland is your Mucoepidermoid Carcinoma. The next most common type was your Adenoid Cystic Carcinoma, which is 22%, followed by your Adenocarcinoma at 18%. A mixture of tumors that has been subdivided as described. The malignant mixed tumor is 13%, your acinic cell carcinoma is 7%, and squamous cell carcinoma at 4%. The mucoepidermoid carcinoma was the most frequent malignancy of your parotid gland, but your adenoid cystic carcinoma was the most frequent of the submandibular and minor salivary gland. Your mucoepidermoid carcinoma is the most common malignant tumor of the salivary glands in adults and children. It is slightly more common in women and have a mean age of occurrence at approximately 4 to 5 years. This can arise from a minor salivary gland in the oral cavity, particularly in the hard palate, buccal mucosal lip, and the retromolar trichome. The patients usually come for medical attention with painless, slow-growing mass, and they usually have both solid and cystic components, often with mucinous materials within the cyst. Microscopically, their hallmark is the presence of the cell types mucous, squamoid, or epidermoid, and intermediate. The architecture is usually a mixture of cystic and solid elements, the latter with sheets, nest, or duct-like structures. The mucous cells have abundant light blue mucin in their cytoplasm, and nuclei are displaced to the periphery. The squamoid cells are large with abundant pink cytoplasm, and although they look somewhat squamoid in appearance, they are not truly squamous. So fine needle aspiration biopsy yields a mixture of cell types. At a minimum, both glandular and squamoid components must be present to make the diagnosis. The mucous cells have abundant vacuolated cytoplasm. Intermediate cells are relatively round and small with little cytoplasm, and nuclei with open chromatin and squamoid cells have moderate amounts of dense homogeneous cytoplasm. In general, low-grade lesions have a prominent cystic component and abundant, well-differentiated mucous cells with little cytologic atypia and low mitotic activity. High-grade lesions are more solid with squamoid and intermediate cells dominating. MRI is more superior than your CT scan, and treatment is surgery with possible neck dissection and radiation therapy. Your adenoid cystic carcinoma is the second most common malignant neoplasm and about 10% of malignant salivary gland tumors. Most common malignant tumor of the minor salivary glands, submandibular, and your sublingual salivary glands. Palate is the most common site in the oral cavity, and it is notorious for its infiltrative growth and a slow progressive behavior with recurrences and spread over the protracted course of years. Propensity for perineural invasion and distant metastasis, wherein the lung is the most common. The lymphatic metastasis is not common except for submandibular origin, and this occurs with an equal incidence in men and women over the wide age range with a peak incidence between 50 and 60 years of age. Grossly solid light tan, firm and well circumscribed but unencapsulated tumors, and microscopically there are three growth patterns that can be described: your tubular, cribriform, and your solid. The tubular pattern are tubule-like structures with an epithelial lining of the small tumor cells with dark chromatin and central ground substance type material, a low-grade tumor. The solid pattern has only rounded lobules of tumor cells with few or no gland-like structures and without defined architecture. The classic and most easily recognized pattern is the cribriform pattern, which is similar to Swiss cheese. The basaloid cells arrange around multiple rounded collections of central basophilic material, giving it a Swiss cheese appearance. It has the best prognosis. The diagnosis is by fine needle aspiration biopsy, and aspirates have tumor cells with scant cytoplasm and round, regular nuclei in sheets and clusters. These features by themselves are not characteristic, and then they might suggest a benign lesion. However, the finding of a well-defined round cylinders and/or spears of cellular stroma accompanying these cells is typical but not 100% specific for adenoid cystic carcinoma. Adenoid cystic carcinoma of the submandibular gland has a much more aggressive clinical course than the other sites. A frequent histologic feature of adenoid cystic carcinoma is perineural invasion, which is identified in approximately 70 to 75% of cases. Worse prognosis, and it's particular when it involves the major nerve trunk. The perineural invasive tumor is probably the source of recurrent tumor even after seemingly complete surgical resection of the primary tumors. Another distinguishing feature of your adenoid cystic carcinoma is that metastasis tends to be distant and most often to the lungs. Distant metastasis to bone is often associated with particularly poor outcome, with a 5-year survival of about 30%. Treatment is complete surgical resection with postoperative radiation. Your acinic cell carcinoma is a tumor with cells that show differentiation towards cells of the normal salivary gland acini. 1 to 3% of all tumors and approximately 10% of all malignant tumors, and more than 90% occur in the parotid, and the rest are scattered among minor salivary gland sites and rarely the submandibular gland. The tumors are relatively evenly distributed in the second through seventh decades, with a peak in incidence in the third decade. Second most common childhood salivary gland malignancy. It is a slowly growing mass which is only occasionally painful and is rarely associated with facial palsy. Your acinic cell carcinoma is found as a single, usually circumscribed rubbery solid mass up to 1/3 would show cystic degeneration. And microscopically, the four principal histologic patterns are your solid lobular, microcystic, papillary cystic, and follicular. Two features are classic, however. The first is the characteristic acinic cell, which has blue cytoplasm and abundant serous-type granules and a small, round, centrally placed nucleus. The second classic feature is a dense lymphoid infiltrate with germinal centers. The periphery of the tumor may or may not be infiltrative, but is often pushing in nature. Fine needle aspiration biopsy of your acinic cell carcinoma is difficult because of its frequent resemblance to normal salivary gland. The diagnosis rests on finding a cellular specimen with sheets and clusters of large acinic cells with abundant granular cytoplasm and central round regular nuclei. There must be a lack of normal ductal epithelial cells and adipose tissue, but a prominent background component of lymphocytes is often present as they are recruited by the tumor cells in most cases of acinic cell carcinoma. Most common is in the parotid gland, which is occasionally bilateral, and most low-grade tumor plus proliferation marker, your Ki-67, would give you a high-grade tumor. There are multiple subtypes that do not have prognostic significance. Treatment is surgical resection with negative margins. is the most important therapy, still tumors will recur in approximately one-third of cases. Classically regarded as low-grade malignancies, overall 10 to 15% of these tumors will metastasize locally to regional lymph nodes or distantly to the lung and bones. Recurrence most likely are local than regional, and survival is approximately 80% at 5 years and 70% at 10 years. Now let's discuss the oral cavity. The oral cavity is a complex organ that comprises your muscle, glands, teeth, and specialized sensory receptors. The mouth is essential for ingestion of nutrients. Incorporation of nutrients by mastication and drinking involves a high degree of coordination within among the different oral motor systems. Chewing requires the reciprocal activation of antagonist trigeminal muscles to open and close the jaws and tongue to position food between the teeth. The local, regional, and distant spread of an oral cavity cancer is dependent on the course of the neurovascular anatomy, lymphatic pathways, and fascial planes to the head and neck. So the latter serves as a barrier to the direct spread of growth and can influence the pattern of growth. Perineural and angiolymphatic invasion can act as a conduit for the spread. Somatosensory innervation of the oral cavity is provided by your maxillary and mandibular branches of the trigeminal nerve and by the glossopharyngeal nerve. The mandibular nerve supplies the oral mucosa of the cheek, anterior two-thirds of the tongue, mandibular dentition, your periodontal ligament, gingiva, and anterior mandibular vestibule. The maxillary nerve innervates your hard and soft palates, the oral mucosa of the maxillary vestibule, and the maxillary dentition, gingiva, and your periodontal ligament. Your glossopharyngeal nerve innervates the back of the tongue and the oropharynx. Overall, the anterior oral cavity displays greater tactile sensitivity than does the posterior oral structure. The tip of the tongue is particularly sensitive with a discriminative capability equivalent to that of the digits, and the midline of the palate and tongue are more sensitive than the lateral regions, and a similar pattern of sensitivity applies to the teeth. The sensitivity to warm stimuli is relatively high on the tip of the tongue, but not particularly so on either the palate or your bucco-labial surfaces. The sensitivity to a cold stimulus is less differentiated within the oral cavity, and the sensitivity of tongue, tip, palate, and bucco-labial surfaces is essentially equal. The sensitivity to cool stimulus is greater compared with your warm stimulus. People usually describe dental pain as either dull and burning or sharp pain. Sensations of your dull burning pain are associated with the stimulation of your C fibers that terminate in the pulp chamber. So your sharp, bright dental pain is associated with the A delta fiber innervation that extends a short distance into the dentinal tubules matrix interposed between the pulp chamber and the enamel covering of the tooth. So this table shows the comparison of the C fibers and the A delta fibers. The taste buds are mainly present in the tongue and palate. However, to a lesser extent, they are also present in the epiglottis, pharynx, and larynx. There are between 2,000 and 5,000 taste buds in the human oral cavity that is distributed on the tongue and the palate. There are 4 different types of your tongue papilla: your circumvallate, fungiform, foliate, and your filiform. All except the filiform papilla contains taste buds and are referred to as taste papilla, whereas your filiform papilla contains no taste buds and are referred to as non-gustatory papilla. Your filiform papilla are covered by partially keratinized stratified epithelium, and they are distributed over most of the oral dorsal tongue surface. Their function is to increase friction between the tongue and food and move particles within the oral cavity. The innervation of all taste buds is via 3 cranial nerves, 7, 9, and 10. The chorda tympani branch of the facial nerve innervates 2 to 5 taste buds on each of approximately 400 fungiform papilla on the anterior aspect of the tongue, and the taste buds on the posterior aspect of the tongue are innervated by the glossopharyngeal nerve, and they are located either in tightly packed clusters distributed along the walls of trenches surrounded 7 to 10 circumvallate papilla, or on the inner folds of the foliate papilla located along the lateral edges of the posterior part of the tongue. Foliate papilla taste buds also receive innervation from your chorda tympani branch of the facial nerve. So this just shows the sulcus terminalis that delineates the anterior and posterior tongue. And the salivary ducts open in your oral cavity is what was mentioned in the previous slide. Your parotid duct or your Stenson's duct orifice is lateral to the second molars. Your submandibular or Warthin's orifice is in the midline floor of the mouth adjacent to the lingual frenulum, and your sublingual or your ducts subvervinus have multiple orifices draining into the floor of mouth or in the submaxillary duct. The hard palate forms the anterior two-thirds of the palate, and this consists of your palatine process of the maxilla and the horizontal plate of the palatine bone. This is covered with your stratified squamous epithelium, which is firmly attached to the bone. The greater palatine foramen conveys your descending palatine branch of the trigeminal nerve to innervate palate, as well as your descending palatine artery at the third division of your maxilla artery, which is 1 centimeter medial to the second molar. Now we'll discuss the disorders of the oral cavity. This is the modified classification scheme of the odontogenic cyst. By definition, a cyst will be considered pathologic cavity at least partially lined by an epithelium. So to be an odontogenic cyst, the epithelial lining must be derived from an odontogenic epithelium. There are a number of odontogenic epithelial stages, and each may provide a basis for autogenic cysts or tumors. The four main components are your dental lamina, enamel organ, reduced enamel epithelium, and your Hertwig epithelial root sheath. Your periapical cyst or your radicular cyst must be associated with a non-vital tooth. The tooth may be rendered non-vital by trauma, caries, developmental defect, periodontal space extension. So this cyst may be seen at any age, although permanent teeth are more likely to be involved than deciduous teeth. They are derived from the rests of Malazes. Radiologically, this cyst will present as a unilocular radiolucency at the apical portion of the tooth. These are long-standing neglected lesions, can get quite large, although most are less than 1 centimeter in diameter. Microscopically, this is a classic inflamed common odontogenic cyst, and as such, the luminal lining will consist of a non-keratinized stratified squamous epithelium, cholesterol slits, foreign-bodied giant cells, and hemosiderin deposits are most common findings. Bacterial colonies may also be seen in these cysts, your actinomycetes colonies, and the treatment is simple enucleation, which is accomplished at the time of tooth extraction. So odontogenic cysts or radicular cysts or your periapical cysts are caused by dental infection. These are asymptomatic. Treatment is what I've mentioned: enucleation, extraction, or a root canal. Dentigerous cysts or follicular cysts must be associated with the crown of an unerupted tooth, developing tooth, or odontoma. Dentigerous cysts form when fluid accumulates between the reduced enamel epithelium and tooth crown. Third molars and maxillary canines are the teeth most frequently impacted. They are also the most likely to be associated with your dentigerous cyst. They are generally found in teenage years and early adulthood, and your radiographic features presents a unilocular radiolucency, which is associated with an uninterrupted tooth. The radiolucency is generally well demarcated and well corticated. The border may become sclerotic or display rarefying ostitis if secondary infection is present. Microscopically, the specimen will present primarily as variably dense, fibrocollagenous connective tissue with some areas being loose and myxomatous. Odontogenic epithelial rests are usually scattered within the connective tissue and are the most common near the epithelial lining. The luminal lining consists of non-keratinized stratified squamous epithelium. Cholesterol slits and their associated multinucleated giant cells may be present in inflamed cysts and when seen are generally associated with connective tissue wall. The treatment are usually easily enucleation at the time of tooth extraction, but for large lesions, decompression with subsequent enucleation may be appropriate. Neoplastic potential appear to retain the ability to transform into true neoplasms, and one study showed that 70% of ameloblastomas were associated with an existing dentigerous cyst. Both squamous cell carcinomas and mucoepidermoid carcinomas have been reported in association with dentigerous. Malignant transformation of odontogenic cyst is fortunately a rare occurrence but nonetheless occurs. There are tables for classification of the malignant odontogenic tumors with other selected malignancies and the classification of odontogenic tumors. Many malignant transformations are considered to arise from residual cysts and occur in an odontolous areas. Malignant lesions are likely to present with pain and swelling, but dysesthesia is a special foreboding symptom. All odontogenic tumors have a malignant counterparts, and the age of occurrence is in the 6th or 7th decade, with some reports of a 2:1. Ameloblastoma intraosseous type is considered the most aggressive of the benign odontogenic tumor. It is a neoplasm of the enamel organ which recapitulates the cells necessary for tooth crown development. Intraosseous ameloblastoma arise from the lining of the odontogenic cyst, reduced enamel epithelium, or odontogenic rests. In the soft tissue of the oral cavity, specifically the gingiva or alveolar mucosa, they may arise from the basal cell layer. Intraosseous ameloblastoma occur in the mandible and maxilla, with the mandible accounting for about 80% of all cases. In the maxilla, ameloblastoma may involve the maxillary sinonasal region as well as their alveolar process. The location of the tumor is a very important factor in long-term prognosis. Radiologically, small ameloblastomas appear as a unilocular radiolucency with well-demarcated and usually at rest partially corticated borders. These radiolucency lesions are indistinguishable from other cysts or benign tumors of the jaws. Larger lesions may become more easy to recognize radiographically. The classic description of larger lesions is a soap bubble or honeycomb appearance. Microscopically, the classic features of ameloblastoma includes a columnar bacillar cells, palisading of bacillar cells, polarization of bacillar layer nuclei away from the basement membrane, hyperchromatism of basal cell nuclei in the epithelial lining, and subnuclear vacuolization of the cytoplasm of the basal cells. Above the basal layer, loosely aggregated pustellate cells resembling the stratum spinosum of developing tooth. Treatment is bone resection with 1 to 2 cm medullary bone margin. Your malignant ameloblastomas are lesions that have any of the classic benign histopathologic features of the ameloblastoma but metastasize to distant location. In many cases, the metastases are long delayed and may occur many years after the initial tumor was treated. The lung is the most common site for metastasis with cervical lymph node involvement. Also reported, treatment varies by degree and site of involvement, although excision is preferred. Radiotherapy may be the only practical option. Ameloblastic carcinoma, in contrast to malignant ameloblastoma, shows cytopathologic features associated with malignancy, with increased mitotic activity, increased nuclear and cytoplasmic ratio, nuclear pleomorphism, and hyperchromatism. Recently, the SOX2 marker has been touted as a potential marker for transformation to ameloblastic carcinoma. The cytopathologic histopathologic features allow for this being diagnosed in the primary location. The tumor may or may not metastasize, but likely the primary tumor, the cytopathologic features, will display the anaplastic features of malignancy. These are very rare lesions. Now we'll go to the oral mucosal lesions. Leukoedema presents as a diffuse and generalized mild surface milky opacification that chiefly involves the buccal mucosa. Factors that may have a role in the manifestation include smoking, cannabis use, alcohol ingestion, bacterial infections, electrochemical interactions, and possibly inflammatory salivary disorders. However, no specific reproducible or definitive cause has been proven to date. The incidence of leukoedema increases with age up to 40 to 49 years. The clinical features: leukoedema is asymptomatic in nature and usually discovered incidentally during routine examination or by the patient. The distribution tends to be symmetric and involves the buccal mucosa and to a lesser extent the labial mucosa. The appearance may be that of a diffuse filmy grayish surface with white streaks, wrinkles, folds, or milky alterations. Histopathologic features shows a surface of the epithelium which is usually parakeratinized. Dominating the histomorphology is marked intracellular edema within the prickle cell or spinous cell layer, where individual cells will appear enlarged and optically clear or vacuolated with peripherally displaced pycnotic nuclei and an overall bland appearance in association with the volumetric increase in the thickness of the epithelial layer. Management of this lesion, this particular mucosal alteration does not require treatment because it is totally benign. The major concern relative to leukoedema is separating it from your leukoplakia. So oral leukoplakia can be defined as a white patch or plaque that cannot be otherwise characterized clinically as representing any other disease entity. This is most common pre-malignant oral mucosal lesion, and most cases are benign and remain so over time. Microscopic evidence of dysplasia is seen in 3.7% to 28.7% of cases of leukoplakia. It serves as a harbinger for the development of oral cancer. In the presence of dysplasia, carcinoma in situ, and invasive carcinoma in relation to oral leukoplakia from all sites range from 17 to 25%. Leukoplakia is most commonly seen in middle-aged and older men, and it is uncommon in men under 30 years of age, and the prevalence rises to nearly 30% in men over 80 years of age. And rates are significantly higher where there is use of betel or your areca nut extract is common. Most commonly associated with leukoplakia is the use of tobacco in its many forms. Included are your smoked tobacco and the several forms of smokeless tobacco. The use of areca and betel nut preparations with or without tobacco form an additional impetus for the development of these conditions in the patient. Along the lower lip vermilion surface, the patches of leukoplakia may develop in response to chronic sun exposure or actinic cheilitis, which demonstrates close relation with the cumulative exposure and the level of cutaneous pigmentation. The clinical features of your oral leukoplakia can range from a thin grayish surface ulceration that demonstrates a white translucent quality with ill-defined margins and generally smooth surface qualities to discrete, sharply marginated, thick and opaque plaques. In general, Such lesions may be homogeneous and smooth, focal or diffuse, or heterogeneous or multifocal with variable textures. Leukoplakia can appear ulcerative, erosive, speckled, nodular, or verrucous to the naked eye. When a clinical shift in appearance occurs from homogeneous leukoplakia to an heterogeneous speckled or nodular form, a rebiopsy is mandatory because of the well-established correlation between increasing levels and frequency of dysplasia. The proliferative verrucous leukoplakia is characteristically aggressive with changing histopathologic features, a more relentless behavior pattern, and greater tendency to develop into squamous cell carcinoma. An uncommon variant of a leukoplakia, it is characteristically multifocal and persistent and tends to be more often in women. An evolution from a thin flat white patch to a leathery thickened and ultimately papillary to verrucous stage characterizes this lesion over time. Its histologic feature characterizes idiopathic or true leukoplakia and ranges from hyperkeratosis and acanthosis to variable degrees of dysplasia or carcinoma in situ and ultimately to invasive squamous cell carcinoma. This can develop into mild, moderate, and severe dysplasia. The management for this idiopathic leukoplakia will depend on the nature of the associated histopathologic findings obtained by your incisional biopsy, because the clinically defined term leukoplakia requires microscopic characterization. Once a lesion has been defined as benign, premalignant, or malignant, a treatment plan can be formulated, and complete removal of these lesions can be accomplished by a wide array of modalities that include your scalpel excision, laser ablation, electrocautery, or cryoablation. In general, there is no effective treatment that is available to prevent the malignant transformation of your leukoplakia. Your oral hairy leukoplakia is a distinctive asymptomatic white lesion of the oral mucosa. It has defined both clinically and microscopically with a distinct relationship in the vast majority of cases with systemic immunosuppression. These are observed in HIV-negative individuals, including those immunosuppressed for a variety of reasons that include your hematologic malignancies and stem cell or solid organ transplantation. Epstein-Barr virus is considered to be the etiologic agent of this lesion that characteristically arises from the lateral tongue margins bilaterally, ranging from subtle white keratotic vertical streaks to thick corrugated and then to shaggy surface alterations. Early lesions may be more smoothly textured and macular in presentation. Less common sites include your dorsum of the tongue, buccal mucosa, floor of the mouth. Diagnosis is by your routine microscopy and in situ hybridization to demonstrate the presence of your Epstein-Barr virus is essential in that the confirmed diagnosis almost always correlates with systemic immunosuppression. The microscopic features suggestive of this diagnosis include hyperkeratosis and irregular surface projections and irregularities. Management of hairy leukoplakia is not necessarily in that establishment of diagnosis remains the crucial task. In patients with proven associations of HIV and AIDS, disappearance of the lesion usually accompanies retroviral therapy. Your Candidiasis is a common opportunistic infection of the oral cavity, oropharynx, and corners of the mouth. The etiology Candida albicans represents the most common Candidal species. Your Candida tropicalis, Candida krusei, and Candida glabrata, among others, are less commonly involved in immunosuppressed and neutropenic patients. However, these latter species are more often present. The risk factors for the development of candidiasis may include local and systemic factors, and the systemic conditions such as poorly controlled diabetes mellitus immunosuppression are associated with oropharyngeal candidiasis. Local effects or altered ecology of the region by topically delivered drugs such as corticosteroids, xerostomia with loss or diminution of saliva's protective function, heavy smoking, and denture appliances favor development of candidal growth. Crucial to the establishment of infection, which implies shift from commensalism, is fungal adhesion to mucosal surfaces and subsequent replication. This table are the clinical forms of oral and oropharyngeal candidiasis. Candidiasis presents as a burning dysgeusia, sensitivity, and generalized discomfort. Odynophagia may be noted in association with pharyngeal or hypopharyngeal involvement. Your acute pseudomembranous candidiasis or your oral thrush have a characteristic soft white superficial colonies of the organisms, may be widespread and is often asymptomatic. Hyperplastic candidiasis or your leukoplakic type hyperkeratosis appears as an asymptomatic keratotic plaques, often placed posterior to the labial commissures along the occlusal line. A triangular pattern of hyperkeratosis is noted with the apex directed posteriorly. Less commonly, similar lesions may be present on the cheeks, palate, and lateral tongue surfaces. Because idiopathic leukoplakia may become secondarily colonized by candidal organisms, confusion may arise, which often demands a tissue biopsy to confirm the nature of the clinical. Confirmation of the diagnosis can be obtained by scraping the mucosal surface, followed by smear preparation and placement of potassium hydroxide over the smear, or use of a tissue stain such as your PAS or your methylamine silver preparations. Treatment. There is a wide spectrum of topical and systemic agents that is available for treatment for several clinical cases. This includes your topical polyene compound nystatin, your azole-triazole group of both topical and systemic agents forms a larger treatment alternative. Then you have your non-absorbable polyene compound in liquid or cream form may be used for most mild to moderate infections, whereas the partially absorbed clotrimazole may be useful both topically and to a lesser extent systematically. Systematically administered triazoles include your fluconazole, itraconazole, and ketoconazole are effective in eradicating more severe forms of disease. There are two types of your herpetic lesions, your primary herpes simplex and your recurrent herpes infection. The primary herpes simplex infection are caused by your herpes simplex type 1, which is a DNA virus, and its incubation period is of 3 to 12 days and lasts 1 to 3 weeks. It presents as a small vesicle on the gingiva, buccal mucosa, tongue, and lips covered by graying membrane accompanied by malaise, fever, and lymphadenitis. This is self-limiting. Treatment is supportive, but lately we use the antivirals. Recurrent herpes infection is also caused by herpes simplex virus 1. It appears as a cold sore or blister at the mucocutaneous junction of the lips and comes from the virus left dormant in the sensory ganglia. Treatment is also supportive with topical anesthesias, mouthwashes, and your antivirals. Your recurrent aphthous ulcer is also known as your canker sore, is a benign ulcerative lesion which affects 20% of people. This appears as a whitish lesion with yellow margins surrounded by a reddish areola, which is very painful. Usually appears on the sides of the tongue, lip, or on the buccal mucosa. The etiology is unknown, but factors that bring them about are trauma from self-biting, injury from sharp food particles, food such as chocolates, candies, peanuts, salted food like squid, shrimp, and fruits, menstruation. This is self-limiting. Treatment is supportive, antibiotic, and pain relievers. Your erythema multiforme or your Stevens-Johnson syndrome. This is a hypersensitivity disease that is that produced a reaction in the skin and the mucous membranes. The precipitating factors are your viral illness, drug reactions, endocrine changes, and underlying malignant disease. This is characterized by iris or target lesions, which have a central vesicle surrounded by alternating pale and red rings. Oral lesions are composed of ulcers and blisters, and this heals within 2 to 3 weeks, but these are recurrent. Treatment are antihistamines, analgesics, oral hygiene, steroids commonly used, but efficacy is not yet proven. We also give antibiotics for this type of patients as prophylaxis. So this table shows the different classifications of the recurrent aphthous ulcers, your herpes simplex, and malignancy. So acute pharyngitis is non-specific, and these are caused by various viral organisms such as your rhinovirus, carovirus, influenza virus, and enterovirus. This may start as a sore throat or be preceded by cold and conjunctivitis, and this may be complicated by secondary bacterial infection. Posterior pharynx congested with mucopus and enlarged lymphoid tissue. This is self-limiting disease in 3 to 4 days. Treatment is symptomatic. Depends on the signs and symptoms. Viral pharyngitis could be caused by herpes simplex type 1, your herpes zoster, or your herpangina. So in herpes simplex type 1, it presents with a pyretic patient with tachycardia, with tender lymph nodes, with vesicular lesions on mucous membranes, occasionally the oropharynx. Herpes zoster is from the reactivation of your viral particles, and this presents as pain on swallowing with vesicles which heal rapidly after attack of chickenpox. Your herpangina is probably due to the enteroviruses that differs from the herpes in that usually spreads its vesicles to the pharynx. So treatment of this is symptomatic, and we also give antivirals. Bacterial pharyngitis can be due to streptococci, pneumococci, and Haemophilus influenzae. Rare cases are from orogenital contact, which is colonized by your gonococcus. So treatment is antibiotics. Your chronic pharyngitis is non-specific, and this is caused by sinusitis, bronchitis, or bronchiectasis, inastasis, which are from smoking or industrial fumes, and occasionally your carcinoma. Your specific etiologies are your syphilis, tuberculosis, leprosy, usually from the nose, fungal, usually immunocompromised patients or HIV positive patients, diabetics, or those on prolonged antibiotic therapy. Treatment is supportive and so your acute tonsillitis, the etiology are your beta-hemolytic streptococcus, H. influenzae, and your pneumococcus. The signs and symptoms are your sore throat, dysphagia, fever, which is especially in exudative type with pus and debris in crypts, fetid breath, autalgia, which is due to referred pain. Treatment could be supportive, like bed rest, fluid, and light diet, oral gargles to soothe the pain, antibiotics, wherein penicillin is still the drug of choice in adults. So for chronic tonsillitis, this is the most common of all throat problems. This is due to the hypertrophic, which are scarred, tonsillar crypts, which express cheesy material which is filled with tonsillitis. Small atrophic types could be turned out stage due to the recurrent inflammation with scarring. Treatment is surgical removal. So your peritonsillar abscess, infection spreads from the tonsil to the surrounding tissue, and this is usually unilateral. The signs and symptoms are your marked dysphagia, referred ear pain, fever, hot potato voice, difficulty opening the mouth, peritonsillar swelling of soft tissue with uvula pushed to the other side. Treatment is antibiotics. Clindamycin is the drug of choice. Alternatives are your penicillin and chloramphenicol. A surgical drainage of the abscess by incision and drainage is usually done in the area where the abscess is, and hot tonsillectomy for this type of patient. Oral tori, torus palatinus and torus mandibularis, represent developmental anomalies that usually present in the second decade of life and continue to grow slowly throughout life. Your tori presents as a mucosa-covered bony outgrowths of the palate and the mandible. The tori of the oral cavity occurs in 3 to 5 to 56% of adults and more common in women, and the tori of the palate are found only in the midline of the hard palate, whereas mandibular tori are found to involve only the lingual surface of the anterior mandible, primarily in the premolar region. Tori are typically pedunculated or multilobulated, rodi-based, smooth, bony masses. They consist of dense lamellar bone with relatively small marrow spaces that do not involve the deeper cancellous bones of the mandible or palate. Patients with tori are usually asymptomatic unless the torus interferes with the denture placement or is repeatedly traumatized when the patient eats. In symptomatic patients, the tori can be treated by removing them from the underlying cortex with osteotomies or cutting burrs. Recurrence is occasionally seen, however, malignant transformation has not been reported. Next, we'll be discussing the benign neoplasms of the oral cavity and the oropharynx. These are the boundaries of your oropharynx. The anterior wall is composed of your base of tongue, the vallecula, the lingual surface of the epiglottis. The lateral wall is your anterior pillar, palatine tonsil, and the posterior pillar. And the roof is made up of your soft palate. The oral surface of the soft palate is part of the oropharynx, and the nasopharyngeal surface is part of your nasopharynx. So these are the different oropharyngeal subunits, which is your soft palate, uvula, the base of tongue, pharyngoepiglottic and glossoepiglottic folds, your palatine arch, your vallecula, your lateral and posterior. Various unique squamous-derived entities of the oral cavity and oropharynx exist. However, one of the most frequently occurring conditions is your squamous papilloma. This approximately is 4 out of 1,000 adults in the U.S. have this condition of the oral cavity or oropharynx. These are the most commonly associated with human papilloma virus 6 and 11 virus subtypes. The lesions typically present in adults and generally have a lower recurrence rate, are singular, and are less proliferative than squamous papillomas of other sites of the head and neck, such as the larynx. The site of occurrence typically involves the lingual, buccal, and labial mucosa and the tongue. Your squamous papilloma typically presents as a single asymptomatic soft pedunculated mass with numerous finger-like projections at the surface. Histologically, the projections have microvascular pores and demonstrated a relatively narrow base. Treatment involves surgical excision or ablation with use of carbon dioxide laser. Recurrence in the oral cavity or oropharynx is unlikely. Your pyogenic granulomas of the oral cavity and oropharynx can occur in any mucosal surface subject to acute or chronic trauma or infection. These arise in association with special events such as pregnancy or recent tooth extraction and result in epulis gravidarum and epulis granulomatosa. Most pyogenic granulomas involve the gingiva. However, other common sites include your labial and mucosal and buccal mucosa and the tongue. Typically presents as raised or pedunculated lesion that remains less than 2.5 cm in size and may bleed with minor trauma. Histologically, your pyogenic granulomas consist of a rich profusion of anastomosing vascular channels in an edematous, inflammatory, and fibrotic stromal background. The lesions usually persist indefinitely except for those associated with pregnancy. Treatment is by excision and removal of potential traumatic or infective factors. Now let's discuss the malignant neoplasms of the Oral cavity malignancies, excluding those of the lip, account for approximately 25% of all head and neck cancers. The primary surgical management represents the typical treatment of choice. The risk factors include your tobacco and alcohol consumption, which are considered the most common preventable risk factors associated with the development of oral cavity squamous cell carcinoma. This relationship is synergistic, with alcohol serving as promoter for carcinogenic effects of tobacco. Smoking confers a 1.9-fold risk to males and 3-fold risk to females for development of head and neck squamous cell carcinoma. Alcohol alone confers a 1.7-fold risk to males who drink 1 to 2 drinks per day compared with non-drinkers. The risk rises to more than 3-fold for heavy drinkers. Experienced e-cigarettes users can obtain the same amount of nicotine exposure as that from combustible tobacco cigarettes. Betel nut, including its derivatives such as your betel quid, is chewed by an estimated 10% of the world population. Oral submucosal fibrosis is a chronic inflammatory reaction associated with habitual use of your betel nut and betel quid, and typically presents as a burning sensation in the oral buccal mucosa that results in severe trismus on examination. With habitual use, and the rate of malignant transformation has been reported to be greater than 5%. Environmental ultraviolet light exposure is associated with the development of lip carcinoma. The projection of the lower lip as it relates to its solar exposure has been implicated in the pathogenesis of squamous cell carcinoma that arise in the vermilion border of the lower lip. Fanconi anemia. Dental restorations in patients with oral carcinoma were 3 times more likely to react to mercury and amalgam compound than non-allergic controls. Older non-smoking denture-wearing patients. Plummer-Vinson syndrome. Patients who have undergone hematopoietic stem cell transplants can develop chronic graft-versus-host disease with significant oral manifestations. Human papillomavirus is an epitheliotropic virus detected on varying degrees with samples of oral cavity squamous cell carcinoma. The overall incidence of oral HPV infection in the U.S. is based on the survey in 2009 and 2010 was 6.9% in men and women aged 14 to 69 years old. Oral human papillomavirus subtype 16 was 1%, and the prevalence of oral HPV was significantly higher in men and was linked to the number of sexual partners in the patient history and the number of cigarette smokes per day. Your leukoplakia is a white mucosal-based keratotic plaque that cannot be wiped free from underlying tissue. This may demonstrate parakeratosis, hyperkeratosis, and acanthosis on histologic examination. Paradoxically, an increased risk of malignant transformation of leukoplakic lesion is seen more commonly in non-smokers. If a leukoplakic lesion is associated with an area of dysplasia in 1 to 3% of all lesions, the risk of progression to malignancy increases sevenfold. Only 6% of lesions in the series underwent subsequent progression to squamous cell carcinoma. Erythroplakia is a red mucosal plaque that does not arise from any obvious mechanical cause and persists after removal of possible etiologic factors. This is associated risk for progression to carcinoma is significantly greater than for leukoplakic lesions. Oral lichen planus is an erosive subtype, has the potential for malignant degeneration to oral carcinoma. The typical patient is a female in the 4th decade of life. Lesions demonstrate a lacy pattern of white striae. Atrophic lesions are red and smooth, whereas erosive lesions have depressed margins and are covered by a layer of fibrinous exudate. Your oral submucosal fibrosis is most frequently encountered in individuals who chew betel nut and is associated with poor oral hygiene, advanced periodontitis, and the potential development of oral carcinoma. Most common oral cancer subsite was the buccal mucosa in more than 50% of cases, and this is followed by the oral tongue. Patients with oral cancer associated with oral submucosal fibrosis were typically younger men with a mean age of 45.11 years, with better histologic differentiation, lower rates of regional metastasis, and a lower likelihood of extranodal spread when compared with their counterparts who had oral carcinoma without oral submucosal fibrosis. Your dysplasia are your abnormal maturation and differentiation of your mucosal epithelium, with features of an increased nuclear cytoplasmic ratio, loss of polarity, increased mitosis, and loss of intercellular adherence. Dysplasia is graded as mild, moderate, or your sarcomatoid squamous cell carcinoma is a spindle cell variant of the squamous cell carcinoma. It is diagnosed in the oral cavity, oropharynx, and larynx, and demonstrates a heterogeneous appearance with spindle-shaped cells interwoven with squamous cells. The diagnosis of sarcomatoid squamous cell carcinoma is confirmed by immunohistochemical staining for keratin markers. It has high risk of local lesional recurrence, and these are more responsive to primary surgical management than chemoradiation. Your basaloid carcinoma is a high-grade variant with a predilection for regional and distant metastasis. However, when clinical staging is matched, 5-year survival is associated. For oral basaloid carcinoma is similar to that of a poorly differentiated and verrucous differentiated oral. Your verrucous carcinoma is a thick zone of non-proliferation and non-keratinizing cells. Distinguishes this entity histologically. The typical presentation is on the buccal mucosa at 50%, and this is considered a low-grade variant of your squamous cell carcinoma and is exophytic in appearance, has the capacity to invade locally, yet carries a low risk of regional spread. This lesion has been considered to be radioresistant, and surgical excision has been the treatment of choice. The sarcomas of the oral cavity usually arises in the mandible or hard palate and include osteosarcoma, chondrosarcoma, malignant fibrous histiocytoma, rhabdomyosarcoma, and the liposarcoma. The patient presents with an osteosarcoma within the maxilla and mandible with approximately equal frequency of 45 to 41%. 5-year local control rate for the head and neck osteosarcoma is 78%, and surgery is performed in all patients, and neoadjuvant chemotherapy was used in 68%. Positive surgical margins were found to be the only significant negative. Of the three main categories of lesion, malignant ameloblastoma was the most common, 59.7%, which is followed by malignant odontogenic tumors at 35.4% and ameloblastic fibrosarcoma at 2.9%. The 5-year survival for the entire cohort of patients was 81%, with patients diagnosed with malignant ameloblastoma having the best mean survival. Your malignant odontogenic tumors encompass a group of diagnoses including odontogenic carcinoma, primary intraosseous carcinoma, odontogenic sarcoma, and ameloblastic carcinoma. For all lesion types, patients with tumors that were 41 mm or greater in size experienced the lowest survival rate. Ewing sarcoma typically presents in children. 1 to 2% incidence of presentation is in the facial skeleton. Most common site of diagnosis is in the mandible at the ramus, so the treatment typically entails wide surgical excision in combination with chemotherapy. If possible, radiation is avoided to minimize the impact on subsequent. Kaposi sarcoma is the most common HIV-associated malignancy. The head and neck is the site for 2/3 of all presentations and may present as a pigmented mucosal nodule and is most commonly seen on the hard palate. Local therapies include radiation, intralesional injection of chemotherapy, cryotherapy, laser therapy, and surgical excision. Systemic chemotherapy is reserved for advanced disease. Now let us discuss the malignant neoplasm of the oropharynx. The oropharynx is common site for presentation of upper aerodigestive tract malignancies, the majority of which are squamous cell carcinoma histopathologically. Tobacco and alcohol consumption have been the traditional risk factors worldwide for oropharyngeal squamous cell carcinoma. More common etiologic association with the human papilloma virus. So this table is the latest WHO classification of tumors of the oropharynx, wherein squamous cell carcinoma is the most common malignancy of the oropharynx and comprises more than 90% of all malignant oropharyngeal tumors. The epithelial precursors of the oropharynx present clinically as white patches leukoplakia or red patches erythroplakia. This was discussed in previous slides. Some lesions appear as mixed variant with white and red components. Most white lesions do not show dysplastic cells and relate to hyperplasia. Erythroplakia or mixed lesions frequently display dysplasia. Hyperplasia denotes increased cells of the spinous layers or acanthosis, or in the basal parabasal layers. The cells are free of atypia and tissue architecture is regular. Dysplasia in the presence of changes in architecture and cellular atypia. The histology is classified as dysplasia, which is characterized as a wide range of microscopic features. It is somewhat challenging to divide the dysplastic spectrum into mild, moderate, and severe. Mild dysplasia is defined by cytologic atypia limited to the basal third of the epithelium. Moderate dysplasia is by extension into the middle third, and severe dysplasia is by extension into the upper third. Carcinoma in situ is described as malignant transformation without invasion and is considered by the WHO as synonymous with severe dysplasia. Oropharyngeal squamous cell carcinoma is an invasive epithelial neoplasm with varying degrees of squamous differentiation and a propensity to early and extensive lymph node metastasis. The neoplasm that may be exophytic, endophytic, ulcerated, verrucoid, or papillary in growth. Severe dysplasia and carcinoma in situ are common elements found in association with invasive squamous cell carcinoma, but are mainly seen in patients with history of tobacco and alcohol consumption. These are rare in the presence of human papillomavirus-associated pathology. Invasive carcinoma eliminates the regular cellular architecture and can include invasion of the lymphovascular space, neurotropism, infiltration of other tissue components as a muscle or cartilage, demonstrating the aggressive behavior of the tumor. Human papillomavirus-associated oropharyngeal squamous cell carcinoma can vary from keratinizing to non-keratinizing and well-differentiated to poorly differentiated. Your human papillomavirus-associated oropharyngeal squamous cell carcinoma displays a histomorphology that is distinct from the traditional tobacco-alcohol-associated keratinizing squamous cell CA. These tumors frequently lack keratinization and mature squamous differentiation. Type 1 is keratinizing squamous cell carcinoma is associated with a strong smoking or drinking history. Type 2 is a hybrid, an intermediate, or mixed category with features of both keratinizing and non-keratinizing squamous cell CA. Most seen in patients with human papillomavirus-associated tumors who have been exposed to chemical carcinogens, and type 3 is non-keratinizing squamous cell carcinoma. Whereas type 3 is common in human papillomavirus-associated tumors, approximately 70% are non-keratinizing squamous cell carcinoma. The presence of cytologic atypia and mitotic features will lead to the correct diagnosis. So from figure left to right, type 1 is the keratinizing squamous cell carcinoma with irregular nests of tumor cells in a reactive desmoplastic stroma and abundant eosinophilic cytoplasm. Your type 2 is in the middle, is a non-keratinizing squamous cell carcinoma with maturation with features of both keratinizing and squamous cell carcinoma and non-keratinizing squamous cell carcinoma. Your type 3 is a non-keratinizing squamous cell carcinoma with rounded nest of tumor cells that have round to ovoid nuclei and dense chromatin. The morphology is typical for P16 positive human papillomavirus associated oropharyngeal carcinoma. Your lymphoepithelial carcinoma is defined as a poorly defined squamous cell carcinoma or undifferentiated carcinoma accompanied by a prominent reactive lymphoplasmacytic infiltrate. It is rare and diagnosed in 0.8 to 2% of all oral and oropharyngeal malignancies. More than 90% of the lymphoepithelial carcinomas in the oral and oropharyngeal region are found in the tonsils and base of tongue, although some are found in the buccal mucosa and in the palate. The histopathologic pattern is described as invasive and comprises syncytial sheets and clusters of carcinoma cells with prominent nucleoli, ill-defined cell borders, and an often intact surface. The tumor sites are accompanied by a rich lymphoplasmacytic infiltrate. These tumors are radiosensitive and local control can be achieved in high percentage of cases. This Kaposi sarcoma, which was discussed earlier, is a soft tissue tumor, a locally aggressive growing neoplasm that can present cutaneously, but it can also present as a mucosal lesion that shows multiple patches and nodules. It can affect lymph nodes and visceral organs. It rarely metastasizes and is grouped into the intermediate type vascular tumors and is associated with your gamma-2 human herpes virus 8 infections. The isolated Kaposi sarcoma of the oropharynx is rare but can be present in the soft palate or tonsil. The oropharynx has been considered to be the main viral reservoir which may contribute to the human herpes virus 8 in saliva. Clinically, this presents as a reddish blue or brown nodules or plaques with possible ulceration. The AIDS-related form of Kaposi sarcoma is the most aggressive form. This is a three-pathologic stage, the patch stage, which is found in early lesions, the plaque stage, and the nodular stage. The early lesions are uncharacteristic and show vascular proliferation, collagen fibers, hyaline globules, endothelial cell lining, cells with some atypia, and infiltration of inflammatory cells as they grow. Patients might be treated with surgery, radiation, chemotherapy, depending on the epidemiology of the disease. The incidence and course of the disease have been improved with retroviral therapy in HIV-infected patients. Your non-Hodgkin's lymphoma are found in the palatine tonsils, palate, base of the tongue, and other oropharyngeal sites. Etiologic factors are unknown in most patients, although some lymphoma patients might suffer from immunodeficiency. Clinical symptoms can include fullness of throat, dysphagia, snoring, and pain. Systemic symptoms are rare. The lesions present as exophytic masses, submucosal swelling, and sometimes ulcerations. Most non-Hodgkin's lymphoma in the oropharynx are B-cell lymphomas, and diffuse large B-cell lymphoma is the predominant type. Histopathologically, the stroma is densely infiltrated with lymphoma cells, which may vary depending on the histologic type. Treatment is based on radiotherapy with or without chemotherapy, depending on the histologic type and stage, and the 5-year survival rate for localized disease has been reported to range from 50 to more than 80%. Next is your solitary extramedullary plasmacytoma, which is a rare hematologic malignancy, and 80% of these tumors arise in the mucosa of the upper aerodigestive tract. Radiotherapy is the treatment of choice. Surgery is considered to be inadequate even with negative margins. The local control rate after radiotherapy is 80 to 100%, and chemotherapy has no role in the treatment. Your mucosal malignant melanoma is the most common manifests as skin lesions, and about 1.3% can arise from melanocytes in the mucosa. 55.4% are mucosal malignant melanomas of the head and neck, which is characterized as malignant transformed melanocytes at the epithelial connective tissue interface, with migration into the epithelium and the connective tissue respectively. Oropharyngeal mucosal malignant melanoma is exceedingly rare, with more mucosal malignant melanoma in the head and neck occurring in the oral cavity. There is no known risk factors except for mucosal malignant melanoma of the head and neck. Clinically, lesions can present as black, gray, or reddish. They are rarely amelanotic. They typically consist of widespread, multiple pigmented lesions with or without nodules. Ulcerations and bone infiltration are common, and oral bleeding, dysphagia, and sensations of pain can occur as symptoms before diagnosis. Your mucosal malignant melanoma is usually diagnosed as an advanced stage, and most tumors can have invasive character. However, 20% are in situ lesions. Aggressive surgical resection is still the primary treatment of choice, although many adjuvant modalities, including different chemotherapy regimens and radiotherapy, have been applied. Despite surgically achieved possible local control, 5-year survival of the pharyngeal melanoma is only 13%. With early detection, melanoma patients have the best chance for cure, and the physician's threshold for biopsy of suspected lesions should be low. Squamous cell carcinoma. The etiology is traditional smoking and alcohol consumption, which has synergistic risk factors. Smokeless tobacco chewing is a common habit. It is the major risk factor for oropharyngeal cancer in these parts of the world. High-risk human papillomavirus 16 is identified as the oncogenic subtype in 90% of HPV-associated oropharyngeal squamous cell carcinomas, but other subtypes such as 18, 31, and 33 can also be present. Tumors typically present in young to middle-aged, healthy, non-smoking, non-drinking Caucasian males. Non-human papillomavirus-associated oropharyngeal squamous cell carcinoma occur predominantly in adults in the 5th and 6th decades of life with history of smoking and alcohol abuse. Epidemiologic studies propose that having multiple sexual partners and engaging in oral sexual behaviors is significantly associated with human papillomavirus infection and human papillomavirus-associated oropharyngeal squamous cell carcinoma. So this table shows the differences between traditional non-human papillomavirus-associated and human papillomavirus-associated oropharyngeal squamous cell carcinoma. So clinically, the patients with oropharyngeal squamous cell carcinoma often presents as advanced stage due to the non-specific nature of the symptoms with early tumors. The symptoms mainly occur as dysphagia, foreign body sensation, or pain in the throat, oral bleeding, referred atalgia, or neck mass. The cancer of the soft palate almost always occur on the ventral surface. They are easily detectable and can be biopsied in office in most cases. The lesions from this location can extend into the tonsil, retromolar trigone, or nasopharynx. Your level 2 nodes are primarily involved. Metastasis to other levels depends on the clinical stage, whereas midline and paramedian lesions have tendency for bilateral lymphatic spread. This becomes infrequent with major lateral located tumors. The squamous cell carcinoma of the tonsillar fossa commonly involves the palatine tonsil and anterior tonsillar pillar. This lesion often presents as foreign body sensation in the throat with dysphagia, atalgia, or impeded jaw mobility caused by infiltration of the periosteum or bone of the mandible or the pterygoid muscle in advanced cases. The lateral extension into parapharyngeal space can be present in the cranial nerve palsies that involves cranial nerves 9, 10, 11, and 12, or the sympathetic chain. Physical examination can show exophytic or ulcerated lesions. Extension into the base of tongue inferiorly and the soft palate superiorly is common. It affected 55% and 60% of patients respectively. Lymphatic drainage is directly directed primarily to the level 2 nodes, but it can involve retropharyngeal and parapharyngeal nodes, level 3 and 4 nodes. The level depends on the stage of presentation. Compared with 45% in patients with cancer of the tonsillar pillar, with the most common node involvement in level 2 for both locations. Contralateral nodal disease was found in 11% of patients with cancer of tonsil and 5% with primary malignancy of the pillar. The cancer of the base of the tongue is difficult to detect and often becomes clinically evident in an advanced stage due to the relatively late clinical symptoms. Because the base of tongue has paucity of free nerve endings, assessment of the base of tongue can be more difficult. So during physical examination, because of the prominent lingual tonsils or submucosal location of the lesion, occult carcinoma with clinical prominent metastatic disease typically in level 2 is often found and is the presenting feature. To rule out findings, meticulous microendoscopic examination and biopsy of suspected lesions are mandatory. The cancer of the base of the tongue has a higher frequency of bilateral metastasis, up to 20%, mainly because of the proximity to the midline, and it has a rich lymphatic drainage. Ipsilateral node involvement is detected in more than 70% of cases. The tumors of the posterior pharyngeal walls. Delayed diagnosis is also common in these tumors. So the symptoms can be pain, dysphagia, and bleeding. Infiltration of the prevertebral fascia posteriorly and deep cervical structures and vessels laterally limits therapeutic options and negatively affects the prognosis. Lymphatic spread is found in about 25% of P1 cancers and in 75% or more of P4 cancers. So most pharyngeal wall tumors come close to the midline or cross it with frequent bilateral lymphatic spread. Microscopic retropharyngeal parapharyngeal lymphatic spread has to be considered even in small lesions without palpable cervical nodes. For diagnostic evaluation, anamnesis, which is part of the comprehensive evaluation of the patient with cancer of the head and neck. Physical examination should include inspection and palpation, especially at the tongue base and tonsillar fossa, sensate testing, and an office endoscopy, either flexible or rigid. Examination can unveil local tumor extension and nerve infiltration. Video endoscopy and documentation of findings are helpful tools for record keeping and future comparisons. Bimanual palpation of the neck is mandatory to assess lymph node status and possible regional metastatic spread. The oropharyngeal malignancies, especially with their close anatomic relationship to important soft tissue, vascular, and bony structures, require imaging of the precise evaluation and treatment plans. Most oropharyngeal malignancies are evaluated using computed tomography or magnetic resonance imaging. Advanced oropharyngeal malignancies may include bony structures such as mandible, maxilla, cervical spine, and skull base, and a CT scan might be helpful in interpretation of bone infiltration. Modern MRI precisely demonstrates infiltration of your periosseous membrane and allows for acute interpretation of bone involvement as well. Your MRI is helpful, especially in deep invasive malignancies, although it can lead to false negative results when lesions are superficial. Your positron emission tomography with CT can help in the search for unknown primary, synchronous primary tumors, and distant metastases. Grayscale and Doppler ultrasonography studies of the neck have proven to be valuable methods for evaluating lymphadenopathy of the neck. Your ultrasound has been proven to be more sensitive and specific in neck node imaging than CT and PET-CT. Human papillomavirus-associated oropharyngeal squamous cell carcinoma is frequently associated with a distinct pattern of intranodal cystic degeneration. The use of ultrasound for cervical assessment has its advantage. It is a relatively inexpensive procedure with real-time imaging in the absence of radiation exposure and can also be performed by a surgeon in the office. Fine needle aspiration can be done under ultrasonographic guidance for the purpose of establishing the histologic diagnosis. The use of ultrasound as a sole diagnostic modality has its limitations, Retropharyngeal nodes and deep structures are not accessible using ultrasound and need to be evaluated in the CT/MRI imaging done for the primary. Imaging is used to screen for distant metastatic spread in organs such as your lung, liver, skeletal system, and brain. On the basis of the primary malignancy and accompanying likelihood of distant metastasis, chest radiographs and ultrasound of the abdomen might be sufficient staging methods. The CT of the lung and CT and MRI of the abdomen are recommended. PET-CT has been growing importance in the detection of distant metastatic spread. To further diagnose oropharyngeal lesions, a biopsy and histopathologic examination must be performed. Biopsies of easily visible oropharyngeal tumors, such as those of the tonsil and soft palate, can be performed in the office under local anesthesia. In patients who present with an enlarged lymph node, fine needle aspiration biopsy can provide a quicker diagnosis with less discomfort. It is also helpful for obtaining a tissue diagnosis in patients with no obvious primary lesions. The best diagnostic results are found with fine needle aspiration using ultrasound guided of the neck. Most of the tongue base, inferior tonsillar or posterior oropharyngeal wall lesions are not sufficiently accessible in the office setting and may require general anesthesia to obtain a biopsy of an adequate sized specimen. Occasionally, small oropharyngeal malignancies can be difficult to detect by physical examination as well as by imaging, so these demand further diagnostics. Pan-endoscopy under general anesthesia is an important tool not only to detect lesions, define their extent and biopsy, but also to rule out any secondary malignancies which can be found in patients with cancer of the head and neck. Pan-endoscopy includes endoscopy of the bronchi and the esophagus. The utility of the frozen sections for confirmation of both a suspected malignancy and tumor-free section margins have been critically evaluated in the past. Frozen section results are close in accuracy in the final diagnosis, which is approximately 90%. The American Joint Committee on Cancer, in its Cancer Staging Manual, defined a new staging cancer system by human papillomavirus status for the oropharyngeal cancer. This table separates systems for human papillomavirus associated with non-human papillomavirus associated tumors as defined by the P16 IHC status. The staging for regional lymph nodes and those with distant metastasis. And this is the table for the management for the algorithm of the squamous cell carcinoma. This can also be found in the book. So that is all you need to read Cummings. I just mentioned the common diseases of the salivary gland, oral cavity, and oropharynx. Thank you.